So, as I mentioned, what I'm going to talk about, and these are my disclosures, most importantly that I'm the medical monitor for the Euphrates trial that I'm going to talk a fair bit about. But what I'm going to talk about very briefly, because I think it's been done very, very well by a number of my predecessors today, is the rationale for sorbent therapy and sepsis, with a little bit more of a focus on the role of LPS or endotoxin. Talk about some of the therapeutic options that, again, apologies as a Canadian, the vast majority of these options are not available in Canada or North America. And so while I know that there are a number of other devices that I won't talk about that exist in Europe, we have very little of this available to us in the North American market. And then I'll talk about some of the work we've been doing with polemics and dechemoperfusion, and where we hope to take these things in terms of elevating the iceberg out of the water, as per Dr. Villa. So what's hot and what's not in Sepsis 2016? We all saw the new JAMA guidelines, which I'll allude to in a second. I think that's a field driven by device therapy, that's driven by big data, by diagnostics, maybe by stem cell therapy, and we're moving away from drugs and perhaps synthetic colloids, high-frequency ventilation, as Dr. Gibney alluded to. But we're really in an era of sepsis that's gone from describing the whole disease as cancer to now realizing there's lung cancer, there's colon cancer, there's stomach. It's a disease of organs. And so as the new definition of sepsis alludes to, it's a focus on organ failure where you have dysregulated host response leading to organ dysfunction. And it's this organ dysfunction that drives outcomes. And in fact, Tim Evans wrote a very nice editorial almost 20 years ago, a review in intensive care medicine, where he said 70% of mortality and sepsis is related to organ dysfunction. And that's been shown in a number of other studies. And so if you actually go to the nurses in my ICU and you ask them to prognosticate for patients, the rule of thumb they use is this one. For every organ failed, your mortality goes up by 20%, and that's been borne out by some of the studies done by Jean-Louis and the SOAP group in Europe, as well as through Prowess and others. And more or less 20% per organ is about right, even. And so how does endotoxin come back into this? Well, as far back as the late 19th century, when you had the work of Pfeiffer and Koch and later Louis Pasteur, there was a recognition that you could take, in fact, killed gram-negative bacteria and just inject animals and patients with the outer cell wall of these gram-negative bacteria, and that looked like sepsis. They would become febrile, hypotensive, and if enough is given, shock and multi-organ failure evolves. And in fact, it was later realized in the United States by a number of biochemists that it's in fact the lipid A portion of endotoxin, which is conserved across all species of gram-negative bacteria, that induces this septic response. There's a nice New England Journal article or case report from 1993 where someone tried to kill themselves by 1 milligram of salmonella endotoxin at the NIH as part of a lover's quarrel, and actually a very nice systemic inflammatory response and ensuing shock developed that the patient was later rescued from, unfortunately. Also, the work of Bruce Beutler and others, who in fact won the Nobel Prize for this work with the discovery of the toll-like receptor 4, which is the key modulator of LPS on the cellular surface in humans, that leads to the downstream cytokine cascade and in fact multiple redundant signaling cascades that help drive the biologic activity of endotoxin or LPS. In fact, my colleague John Marshall has often said that endotoxin is more of a hormone or an exohormone than it is an endotoxin, because we have such a highly conserved, highly developed mechanism for dealing. And so in simpler form, we know that endotoxin injection leads to the very rapid increase in TNF-alpha, interleukin-6, followed by the anti-inflammatory mediators, IL-10, and other downstream mediators. But more importantly, when we bring it to the clinical scenario, we know that endotoxin in the blood leads to death. And so when you the 13-center medic trial that was done by John Marshall and others in Europe and North America, when we measure endotoxin levels in the blood in septic patients, we know that it's an independent predictor of hospital and ICU mortality. This is a similar study done by Steve Opel and others some years earlier. And in fact, I can tell you data now in over 1,000 patients in the Euphrates trial, it is absolutely clear that endotoxin levels are an independent predictor of death in patients who are otherwise similar. So we have a biochemical phenotype, again, as Dr. Villa alluded to. But moving beyond a biologic phenotype, if endotoxin, as many have said, is just the initiator of the septic cascade, then should we be focused on this from a therapeutic direction in the ICU? We're seeing the patient sometimes some hours, many hours after they've come to the emergency room. Their sepsis maybe even started days before at home. Is endotoxin still playing a role? And so as a critical care fellow, John Marshall and myself looked at levels of endotoxin in patients measured in the MEDIC trial over the first 4 days of their ICU admission. This is approximately 800 patients, and in fact found that not only levels of endotoxin persist over time, I haven't included that slide, but certainly they do, but in fact it's the total area under the curve of how much endotoxin you're exposed to that's directly associated with your degree of organ dysfunction over that time period. And in fact, that variability in endotoxin levels over time, as per the hypothesis that we've talked about earlier today, that in fact is the single largest predictor of organ dysfunction and subsequent death. So in fact, here's some data that in fact endotoxin burden and variability in endotoxin can drive organ dysfunction and death. And so here's the history of all the drugs that have been tried in the ICU over the last 20 years. It's been said that this represents almost $20 billion and many, many thousands of man-hours and patient lives that we know don't work in the ICU. And so extracorporeal therapies and other ways of targeting this pathology. So however you do it, extracorporeal circuits are fairly simple. They're typically veno-venous circuits set up through some form of a blood pump, whether that's a CRRT or intermittent hemodialysis machine or a dedicated hemoperfusion pump. And just to describe some of these that have been developed, some people have alluded today to or semi-selective membranes for the reduction of cytokines in sepsis, and one that has recently become available in the North American market is Cytosorb from the Sorbent company. Not something that's been subjected to multi-center trials that have as yet been published. Unfortunately, some recent data in critical care that was somewhat discouraging in cardiopulmonary bypass patients that showed a failure to reduce cytokine levels in with the exception of a minor, potentially significant benefit in IL-10 as a counter-regulatory hormone or cytokine. Another is the Alteco LPS adsorber from Scandinavia. Again, largely studied in single-center trials, particularly in cardiopulmonary bypass, both in Scandinavia and to some extent in Russia, with a few case reports and small studies. The evidence to date is quite limited and has not yet been subjected to larger clinical trials. Another device that was developed by the Gambro company, now Baxter, is the Oxyrus platform. Another semi-selective membrane thought to remove LPS. Again, quite limited data, and as far as I'm aware, not widely available even in Europe at this time. Compare some of these different endotoxin removal filters and try and get a sense as to what their capabilities are. Certainly what we know about polymyxin B hemoperfusion is its absorption capacity for endotoxin is approximately 50 to 100 times greater than the other marketed filters. Does that matter clinically? Well, so we developed, the group of Dr. Ramachin, and Dr. Walker in Toronto developed the endotoxin activity assay nearly 20 years ago to help look at levels of endotoxin in predominantly septic patients. And what you can see is that in the high range, which is the typical range observed in patients with sepsis, you can see LPS levels of 5,000 picograms per ml. So if you imagine that in a patient with a 5-liter blood volume, you're literally facing tens, if not hundreds of thousands of far exceeding the capacity of some of the other membranes. And that's not even getting into some of the other issues that were raised by Callum and others about compartmentalization of cytokines and endotoxin. And so, again, in a number of studies that were done, both modeling done by myself and others, as well as some Japanese studies and animal models, it's been shown that the endotoxin absorption capacity of the polymyxin B hemoperfusion column is really, really quite robust. Another concept we introduced a number of years ago is the concept of endotoxin burden, which is really this notion of area under the curve for how much endotoxin you're exposed to. And so this is a case that was an early example of this from Japan, where we measured endotoxin activity levels in a patient with sigmoid perforation and septic shock, just to really see if the assay was responsive to polymyxin B hemoperfusion, and in fact observed a 92.5% in endotoxin levels after standard treatment with 2 polymyxin B hemoperfusion columns. So quite a robust therapy in terms of its ability to remove endotoxin. So just to describe the filter in more detail, the polymyxin B is bound covalently to polystyrene in a column to prevent elution of polymyxin B into the systemic circulation, which is both neurotoxic and nephrotoxic. And the binding affinity of polymyxin B for the lipid A portion of the endotoxin molecule is thought to be, in fact, has been measured to be on the order of a factor of 10 to the 13 through both ionic binding forces and, in fact, hydrophobic binding forces. This is work that was done here in Italy, our esteemed colleagues in the room. And so polymyxin B can remove LPS both by directly stripping LPS out of the bloodstream where it exists free in circulation, as well as in micellular form with HDL and lipids, as well as bound to albumin because of its high binding affinity. But in addition to that, because the binding is so high between LPS and polymyxin, and because TLR4 receptor on monocytes, you can, as alluded to in Dr. Villa's presentation, directly strip monocytes complex to LPS TLR4 directly out of the bloodstream, as shown here in electron micrography. But again, let's get back to our clinical case. So you had case reports really in the late 90s and small individual case series of polymyxin B hemoperfusion reducing endotoxin levels in the blood and some resultant good outcomes. And then Dina Cruz, Claudia Ronco here, and others decided to look at some of the available literature in a meta-analysis that was published in 2007 in Critical Care, which showed that in these small trials, when pooled, there was significant effect size on mortality related to use of polymyxin B hemoperfusion. But again, these were largely trials done in Japan, and so there was a desire to do a European trial, again led by Dr. Ronco, Dr. Antonelli, Cruz and others to try and validate whether or not polymyxin D hemoperfusion in fact was effective. And so they took a patient population that they believed had a high likelihood of circulating endotoxemia, but did not measure endotoxin levels as it wasn't widely available at that time to use EAA in Italy, and subjected these patients to patients with septic shock with very high mortality, polymyxin D hemoperfusion. And they gave 2 treatments 24 hours apart as the standard is, and in 64 patients showed quite dramatic reductions in SOFA score, driven predominantly by improvements in cardiovascular SOFA, so improvements in blood pressure, reduction in vasopressor doses, as well as minor improvements in respiratory score, and again a significant improvement in renal SOFA, so a reduction in the incidence of CRT. And so mortality in this study, where mortality in the placebo group ranged from 53 to 67%, was quite dramatically impacted, decreasing on an absolute basis by 21% at 28 days. And so John Kellum wrote a very nice editorial accompanying this manuscript in JAMA, where he talked about if you were on a plane heading from Los Angeles to Tokyo and you developed septic shock, whether the plane turned around and landed in LA or continued on to Tokyo, you would get 2 different treatments. And so there was a real need, despite this updated meta-analysis that he did, showing again significant benefits for polymyxin D hemoperfusion, to do a definitive trial. Prior to the definitive trial that I'm going to talk about, there was this other European study that was done by Didier Payen's group out of France, where they did a trial in patients post-operatively with sepsis, septic shock, and no benefit whatsoever to use of polymyxin D hemoperfusion. But compared to the UFA study, where placebo mortality or control mortality was 50 to 60%, their composite mortality was 22%, and thus their study was significantly underpowered for what they had estimated. Another somewhat troubling observation from the Abdomic study in a room full of nephrologists and CRT experts is their rate of cartridge failure in the study was 30%, compared to what we've observed in Euphrates and what was observed in UFAS, rates of 5% or less, and in fact, in many cases, 1 or 2%. In addition, of course, they didn't measure endotoxin levels in that study. And when we did a second look at the data, it was also interesting to note that it was really the cartridge failure rate that drove the mortality in the treatment group rather than with severity of illness. So I think the study has some value, but one that should be taken with a significant grain of salt. And so an updated meta-analysis was done using the Payen results, and although it still does show some significant benefit to polymyxin B, clearly we arrived at a point of, at least on a global level, of where there is significant clinical equipoise for a large trial. Interesting study that I just put in this morning. This is some registry data from Dr. Kent Doi in Japan, where he looked at a patient population who received polymyxin D hemoperfusion that were already on CRRT, and in fact showed a significant reduction in this registry study in mortality. And more importantly, at least from my own perspective, he showed a dose response in this patient population between patients who received no columns, 1 column, and 2 columns, or 2 sessions of perfusion, even when controlled for other measures of severity of illness. And so what do we think is driving some of the responders versus non-responders to polymyxin hemoperfusion? Well, clearly there seems to be an association between baseline severity of illness and control mortality in this patient population. And you can see that the benefit of PMS seems to be almost directly related to the mortality in the observed controls. So moving to Euphrates, the definitive North American trial. This trial is led by Phil Dillinger in the United States, the principal author of the Surviving Sepsis Guidelines, and is supported by Spectral Medical. It's a blinded, randomized clinical trial of polymyxin B hemoperfusion in patients with septic shock in 60 ICUs in 450 patients with 2 treatments 24 hours apart. The trial is made unique compared to other trials, and hopefully this is where we are elevating the iceberg somewhat, in that it uses as an entry criteria the endotoxin activity assay, where you have to have an endotoxin activity assay level of greater than 0.6, or in fact high circulating levels of endotoxin to be enrolled in the study and randomized. And so to achieve that, we've had to screen otherwise eligible nearly 1,000 patients to achieve 4 patients that have high endotoxin levels in the trial. And so we have patients with septic shock, high endotoxin levels, and also an organ failure requirement that was added by the DSMB after the first interim analysis to ensure that the severity of illness that we are targeting in the study is in fact achieved. And I can tell you, with 4 patients left to enroll in the trial, that at least on a composite mortality basis, we're achieving our goal. The mortality is just over 50% in the randomized population. So in conclusion, I think that we are in an era of extracorporeal therapies, and I think that they are both biologically plausible for sepsis and septic shock, and something that we can target as we learn the phenotype of our patients better. But also, as we move from drugs to devices in the ICU, we shouldn't avoid or forget the lessons of drugs, and we should be subjecting our devices to studies, and when possible, there should be blinded studies that are driven by hard endpoints like mortality, and where possible, in fact, to personalize those therapies to our patients. And I hope to return to present the results of Euphrates to you this time next year. Thank you.